All right, so this lecture is applicable to anyone who either knows anyone with dizziness, has had an acoustic neuroma, is considering acoustic neuroma surgery. It is really applicable to anyone in any circumstance of dizziness. So hopefully you will appreciate some benefit from this. So when it comes to dizziness, the most important thing is to figure out what the heck you mean when you say dizzy. And so this is often very challenging for many clinicians because it's really challenging for the patient to understand what that means by saying dizzy. And so I just want to take a few minutes to describe what dizziness could potentially mean. So first of all, vertigo is a symptom. Okay, it is not a diagnosis. Many times patients will say, well, I was diagnosed with vertigo from the emergency room, and I have to take the time to explain to them that vertigo is a type of dizziness that can be caused by a multitude of things. So vertigo is the illusion of movement. It can be that spinning sensation, but it can also be movements that are up or down or left and right. And vertigo can be a problem of the inner ear, or it can be a central vestibular disorder, meaning coming from the brain. Now, syncope is entirely different from vertigo. Syncope is when you actually lose consciousness that is not associated with the illusion of movement. And so when we think about syncope, we think about passing out. And oftentimes this is a vascular disorder. Obviously, that's not the single cause, but that's likely the most common. Obviously, there are other circumstances that can play a role in this, but I just kind of wanted to touch base on some of the most common things. The next thing is disequilibrium. Disequilibrium is a really challenging term because, again, disequilibrium can mean many things to different people, but essentially it's the sensation of an imbalance without vertigo. So it's not the illusion of movement, it's not loss of consciousness. Oftentimes patients will say they kind of feel like they're drunk, or they're wobbly, or they can't walk a straight line, or they have trouble doing tasks that require good balance. And so the common underlying cause for this is visual or somatosensory impairment, and we'll talk more about what that means. And then the last term that I like to include in the differential is this lightheadedness, this woozy, this wonky, or this brain fog. And I think Morgan Chris is online with us today, and she can take credit for the woozy and the wonky description of this term. And I like to explain that these symptoms can very often be a combination of a lot of things. Morgan also likes to use the term optimizing brain function, and I've used that ever since fellowship. So Morgan, hopefully you get a nickel every time I use that. Alternatively, there can be a component of migraine as well. And it's really important to recognize that older dizzy patients typically present with a different symptom profile compared to the younger counterparts. Younger patients more often complain of that true vertigo, the nausea, and the emesis, whereas older patients more often report symptoms of unsteadiness, imbalance, or disequilibrium. Not saying that elderly patients don't get vertigo, but those are more common. So when it comes to understanding what it takes to have good balance, there's a combination of systems that take place. So the vestibular system includes your inner ear organs, which we'll describe here momentarily, and those help with your equilibrium, spatial awareness, rotation, and linear movement. But without sight, we will not have a strong balance system, and without proprioceptive touch, we won't. There are integration centers in the brain, parts of the cerebellum and the cerebral cortex, and then the integration center in the brainstem. And then, of course, there's motor output. We'll talk more about the vestibulo-ocular reflex. We'll talk about what our limbs do to control the motor impulses of our legs and arms, but also our eye, and then the motor impulses to make these postural adjustments. So the vestibular system is peripherally speaking, part of the inner ear. And so in our inner ear, we have 10 balance organs. The loops, or the canals that we see of the inner ear, are important for rotational components. And then we also have two structures within the inner ear that control horizontal and vertical motion. As we age, or as we appreciate age relation to these symptoms, they have these small hair cells, and these hair cells have been documented to decline as we age. Age-related degeneration of the peripheral, meaning the inner ear, and the central system is similar to that of the auditory system. So in other words, as people have age-related hearing loss, they can have age-related dysfunction of their balance. And this can be due to a multitude of things. There are certainly medicines that we've taken over time, also known as ototoxicity. There could be subtle changes in blood flow. And we've actually found that there's a significant relationship to vitamin D deficiency in the function of those crystals of the inner ear. So when we talk about the output system or the motor system, muscle strength is really important in the foundation of our vestibular system, in the sense that we have to carry out these actions in order to be stable. Unfortunately, over time, muscle strength has been shown to be lowered significantly in the elderly population. They have found 20 to 40% muscle reduction in patients 70 to 80 years old. There's a reduction in muscle strength that is related to a decrease in the number and size of muscle fibers, as well as changes in the central motor command centers. Similarly, the speed with which muscles can be contracted declines with age. These and other similar age-related changes in the skeletal muscles may prevent older individuals from exerting adequate force and reacting quickly to postural disturbances. So obviously you can see how this can impact somebody's system. Secondarily, we often forget about the importance of the visual system. So the visual system undergoes significant age-related changes. In addition to visual acuity, which means your visual clarity, there are several other visual functions such as depth perception, accommodation, contrast sensitivity, adaptation to dark and light scenarios. All these things can decline with age. So if you think about getting a new set of glasses, a subtle change can be significant. In other words, oftentimes people complain of dizziness just with a change of getting new eyeglasses. And this is something that we often adapt to. Eventually, most people get used to this new change. Some people don't, and they are dizzy when they move about in space, particularly using their eyes. In order to see while the head is moving, the eyes must actually stay in place, which means as the head moves, the eye must counter-rotate. And when we do this, we are performing this function by using what's called the vestibulo-ocular reflex, where input from the inner ear and the output is to the eye muscles. So if we have some new glasses, in other words, if magnification of the eye has changed, this means that the world becomes bigger or smaller, and accordingly, the amount of movement of the eye is required from the VOR, or the vestibulo-ocular reflex, to change in order for things to be still. So this ability to modify the VOR gain, in other words, that input and the output from the ear, seems to max out at actually a factor of 2. And thus, if someone has, for example, already lost some of their inner ear function, they may not be able to accommodate to that new eyeglass change. And so this is the understanding that magnification is likely an explanation for some of the mobility problems in older adults. Similarly, we see similar effects after cataract surgery. So even though the cataract has been removed, they still may have significant symptoms after their eye surgery has recovered. Next is the proprioceptive system. So this is the sensation of your muscles, your joints, and your tendons. These provide information regarding orientation of one body segment in respect to another. Proprioceptive cues from the neck also play an important role in detecting head orientation and providing a stable platform for vestibular and visual receptors. Vibration and touch thresholds decline in older individuals, adversely affecting tactile, meaning touch information, arising from their feet to contact point in the ground. So similarly, the ability to detect the position and direction of joint movements declines with age. Concomitant conditions such as diabetes and other peripheral neuropathy are more common in older adults, and these may have a synergistic effect with age-related decline in lower extremity proprioceptive function. So peripheral neuropathy in and of itself is predictive of falls in patients with balance dysfunction. Of course, as we age, the brain takes changes, and the brainstem, the cerebellum, the higher cortical structures within the central nervous system all suffer age-related degenerative changes. These changes include the decrease in the number of neurons, loss of myelination or the nerve sheath, and other neural changes. Age-related degeneration of central structures is likely to affect the integration of information from different sensory inputs and interfere with accurate perception of orientation and motion. So specifically, what are some of the inner ear causes of dizziness? Particularly, the most common are benign positional vertigo, Meniere's disease, vestibular neuritis, and labyrinthitis. Now, like I said previously, many adults don't necessarily have vertigo. They may have issues with disequilibrium, but all of these conditions can cause vertigo. With benign positional vertigo, this is, we could talk about all of these particular instances for an extended period of time, but nonetheless, benign positional vertigo is usually a very short period of vertigo. Patients will experience that room spinning sensation for just a few seconds, and it is a problem, as you may have heard before, with the crystals of the inner ear. Meniere's disease is a condition in which patients will experience not only room spinning vertigo, they may unfortunately experience something called drop attacks, but this is typically associated with fluctuations in hearing. People will experience oral or ear fullness, ringing in their ears, and pressure. Vestibular neuritis is a condition in which people typically experience a sudden onset of severe room spinning vertigo that is followed by chronic disequilibrium. So in other words, there's a long recovery phase even after the severe vertigo has resulted. Labyrinthitis is similar in the sense, but it also includes hearing loss. There may be other conditions that involve the inner ear, but also include the brain. And so one of the most common causes of this is vestibular migraine. That is a condition that can cause a variety of vestibular symptoms. People can experience true room spinning vertigo. They often complain of disequilibrium. They also may complain of headaches. As typical migraines, people experience a throbbing headache associated with nausea and vomiting. But as I explained to patients, migraine is not always a headache problem. You can suffer from migraine, particularly from a vestibular standpoint, without having headache at all. Oftentimes, people will complain of sensitivity to bright lights, and very often complain of a lot of sensitivity to visual activity or visual motion. These patients will have difficulties if they're in a busy environment or at the supermarket, or oftentimes have a lot of discomfort with motion sickness. Persistent perceptual postural dizziness is a condition that is typically stimulated by having some sort of vestibular event. In other words, they had a history of labyrinthitis or neuritis or even benign positional vertigo. It is often associated with vestibular migraine, but these patients have a fear of future vertigo attacks, and the chronic stress and the anxiety and worrying about that future attack can often lead to chronic postural dizziness, as it's described. Some of the non-inner ear conditions that can cause dizziness may be related to the cardiovascular system. So it's really important to consider the relationship between the inner ear and the cardiovascular system. Typically, if there's a problem in the cardiovascular system, people will describe lightheadedness, pre-syncope, meaning they feel like they're going to pass out. And they may also have diagnosed by something called orthostatic hypotension, which basically means their blood pressure changes dramatically when they go from a seated to a standing position. The cardiovascular system is responsive by using the autonomic nervous system. There's something called the baroreflex. In other words, when we change body position, the blood pressure and the heart rate accommodate accordingly. So as you can see in the diagram here, as the patient goes from sitting to standing, there's an initial drop in blood pressure, but there's a responsive heart rate to increase cardiac output and bring that blood pressure back up though. what we don't often appreciate is the importance of the vestibular system in this response. So the vestibular system can notify the brain of changes in position and posture in milliseconds, well before the blood pressure or the cerebral blood flow begin to drop. There is emerging evidence that the vestibular system contributes to this autonomic response to help maintain blood pressure. There actually has been some work done in animals where they cut the vestibular nerve, and they found that these animals had a dramatic increase in postural hypotension. So in other words, they weren't able to have that baroreflex. When we think about the non-vestibular causes of dizziness, as I talked about, thinking about blood flow is very important. We may be familiar with something called atherosclerosis, or narrowing of blood vessels. This can lead to ischemic events and produce similar symptoms to either peripheral or central lesions, depending on the infected site. There's something that we refer to as vertebrobasilar insufficiency, in which the vertebral artery or the basilar system may have an insufficient amount of blood supply, and this is certainly a potential source of dizziness in the elderly population. Other diseases in this category include those of reduced cardiac output. So in other words, if your heart is not functioning appropriately, it's not going to force appropriate blood flow to the brain. You may have arrhythmias or types of heart failure. But we also have to think about neurologic conditions. We need to evaluate for multiple sclerosis, Parkinson's disease, and even various forms of dementia can present as dizziness. Finally, we can't forget the impact of psychiatric disorders, including cognitive impairment, such as dementia. We need to consider this in the elderly. Over 37% of patients with chronic dizziness in the elderly population did have actually an underlying psychiatric diagnosis. Although psychiatric diseases rarely were considered in the part of the primary cause of the dizziness, they were contributing factors. I think that one of the most important things to discuss with patients is their medication list. One of the first things that I look at when evaluating an elderly dizzy patient is their medication list. As you can see, many of these drug classes have effects on blood pressure, and oftentimes patients don't appreciate that these medications could be contributing to their system. More importantly, we have to discuss what pharmacodynamics are. So in other words, how the medication reacts in the patient's body, how it is absorbed, how it's excreted, and so on and so forth. And what I mean by that is it's very important to consider that the medications that somebody is taking may change as somebody ages. In other words, the way that the medication impacts their system or the way that it's excreted may change over time. So if somebody is having issues with blood pressure, you may want to talk to the family doctor about reducing the amount of that medications needed, because over time, they may not need as much. So I just want to go over a few of these. Many patients take antidepressants. This can cause low blood pressure. Anti-Parkinson or movement disorders also affect the blood pressure. Antipsychotics, as you can see, beta blockers are blood pressure medications. Calcium channel blockers are also blood pressure medications. And diuretics. So these are the medications that can cause volume depletion as well. Other medications, so anxiolytics are basically medications that help to reduce anxiety. This can cause CNS depression or central nervous system depression. So if you think about being anxious, being wired, being fired up, these medications bring that down, which may be helpful to control your anxiety, but it's bringing down the entire system, and this can cause vestibular dysfunction as well. Muscle relaxers are medications that people take to obviously relax muscle spasm, but there are side effects to this. It can cause drowsiness and confusion as well. Cholesterol medications, interestingly enough, can cause hypotension. This is actually something that I learned from one of my patients, and I think that it's really important to try to listen to patients, because finding the cause of dizziness can be very challenging. I really try to listen to my patients and learn from them. And like I said, one of my patients recently taught me this, that they came in for the complaint of dizziness. They, on their own, did a little bit of research and found that cholesterol medications can cause dizziness. They stopped their cholesterol medication, and lo and behold, their dizziness completely resolved. So it's really challenging a lot of times for physicians, because we always like to see objective information. We like to see tests, we like to see studies, we like to see images. But if a patient tells you that their dizziness resolved when they stopped their medication, or they tried, you know, one type of treatment versus the other, whether it's placebo or not, and it worked, it doesn't matter, because if it works, it works. And so I'm not going to argue with the patient. I support their decision making. Obviously, if there are things that they have to consider with medical changes, they have to understand the risks and benefits with those things. And it's a conversation they can have with the ENT doctor or the primary care doctor. Now, there are some things that we do need to worry about. So in this list are basically the red flags. So these are symptoms in patients with dizziness that may indicate the presence of something serious. And so these are symptoms that I don't often see in the office, because many of them are more acute symptoms and maybe seen by the emergency room doctor, the urgent care. But nonetheless, I still ask all of these questions, because they can be very subtle changes, and they may actually be something that the patient didn't actually think about themselves. So numbness of the face, weakness of the face, difficulty swallowing, memory loss, unexplained weight loss, slurred speech. Obviously, hearing, we'll always check the hearing in the office, double vision, visual field loss, change in their color vision, or increasing or expanding severe pain. So when it comes to the management of dizziness in the older individual, I really emphasize medical and rehabilitative management. Certainly there are conditions that we do have to operate on, but these patients, as we discussed previously, have had a decline in various portions of their response to their decline. And so, in other words, when you operate, you really need to emphasize the rehabilitative component. If they already have underlying dysfunction, the rehab recovery is going to be a lot more challenging. So the compensation mechanisms deteriorate, and we only do surgery if we have to. So when it comes to medical management, certainly we try to adjust some of their medications. Obviously, if they have an antihypertensive medication, we try to titrate that appropriately. We like to have discussions with the primary care doctor and the cardiologist. Also, like I discussed previously, it's important to consider psychogenic causes. So in other words, managing the anxiety, the depression, and again, reviewing all of those medications. When it comes to rehabilitative, there are certainly physical therapy. So from an orthopedic standpoint, making sure that we have good range of motion, we have good muscle strength, we have addressed the arthritis, the knee replacement, hip replacement, so on and so forth, which also includes exercise therapy. So I always encourage patients to be as active as possible, exercise every single day, keep that strength, keep those proprioceptive neurons firing. And then vestibular therapy is something that we'll discuss a little bit more in detail here momentarily. So when it comes to managing elderly patients in dizziness, I always, again, as Morgan says, optimize brain health. And so we have to do many things to emphasize the rehabilitative process and the recovery process, and certainly prevent further decline. So I always emphasize education. You can't learn enough. I always emphasize exercise, get moving, stay connected. In support groups such as this, I think that diet is very important. There are a multitude of things that people don't even realize that they're eating and drinking on a daily basis that may have an impact. And then taking charge. And what I mean by that is have an investment in yourself. You want to be better. Unfortunately, for many of these conditions, there's no magic pill. And the only way you're going to get better, stronger, and have less dizziness is to invest in yourself. So when it comes to understanding vestibular conditions, it's also very important to have the discussion or even a formal assessment of fall risk. And so certainly if a patient has the chance of falling, there's obviously injury, there's accidental death. This leads to hospital admissions, which unfortunately is physical and emotional costs. And so the challenge is that patients who may not do as well, in other words, have a poor prognosis, they have mobility restrictions, they have loss of independence, and they're confined to nursing homes. So if we can do preventative maintenance and keep people active and moving, we can give them a better prognosis. And so it's important to make an assessment of their falling risk. It's very simple to talk to patients about even things around their house to help to just prevent falls. So if you have a staircase, make sure there's a good strong handrail. Make sure there isn't distractions on the floor, such as, particularly rugs, clothes on the ground, so on and so forth. Be very careful with loose cords. The shower and the bath is really, really important. There needs to be non-slip surfaces in the shower and on the floor. It's also very important to add more lighting. I encourage patients to have night lights throughout the house because, again, that visual stimulation can have a big impact on their balance system. And again, more declutter. So we already talked about medication side effects, vision checks, exercise, and so on and so forth. So now I want to talk about the importance of the rehabilitation provider, because this is something that I emphasize significantly with my patients. And we're going to talk about how the different components of rehabilitation can have a large impact on someone's recovery. And so one of the core exercises of vestibular rehabilitation is what's called the VOR, the vestibulo-ocular reflex. And this is what I talked about before, the importance of having a good vision system. I explain to patients that vestibular therapy is strengthening of the inner ear. It is not the type of physical therapy that focuses on, particularly of range of motion or strengthening exercises. It is a subspecialty of physical therapy that focuses on the development of the inner ear and the central nervous system. And so particularly this VOR, the vestibular ocular reflex, is an exercise in which a patient will typically move their head side to side on a fixed target, or the head and the head and the hand holding a target in the opposite direction with the eyes fixed on that target. So in other words, it's an exercise to strengthen that vestibulo-ocular reflex. The next thing is habituation exercises. So this involves repeated exposure to a provoking stimulus or movement so the pathologic stimulus is reduced. So in other words, getting you to the point where you can tolerate this exposure without developing dizziness. And so these therapists select movements that provoke the patient's symptoms, and the patient repeats these motions until the patient no longer reacts adversely to whatever that stimulus is. The other thing are substitution exercises. This exercise helps the patient improve one channel of sensory input, such as vision, somatosensory proprioception, by blocking sensory inputs from the other two channels. So in other words, to challenge proprioception, the patient closes the eyes and try to maintain balance while standing. The last thing is optokinetic stimulation, and this is a exercise to help people desensitize people who are very sensitive to motion in the periphery. So in other words, if they're looking at a target, and there's motion behind it, okay? So this, a description of this would be having the patient sitting and spin an umbrella about 3 feet away or so from them in a circle while they look at the center of the umbrella. So again, looking at a target while the background is moving. So some other things that people are starting to incorporate into vestibular rehabilitation is virtual reality. And this gives the patient the opportunity basically with limited resources to move about their environment and practice day-to-day activities or lifestyle type things. In other words, moving around the grocery store without having to actually go to the grocery store. There are certainly functional components that may help, things to think about from an occupational therapy standpoint. This is a very simple insert on somebody's shoe. You can see the ridge around the outside, and basically this is a somatosensory stimulus. So in other words, they can feel the edge of their shoe a little bit better, or their platform. I have this one in quotations because Tai Chi is not novel. However, it is something that has been shown to be very beneficial, not only in everyone, but in elderly patients. This is really important because it incorporates relaxation, breathing techniques, obviously balance techniques, flexibility, and strength. Lastly, patients have shown to have a lot of benefit from Nintendo Wii. It is fun, it's engaging, people are able to play games, they're able to use this as a form of exercise, obviously challenge their balance system, and do it in a proactive and fun way. And so in conclusion, when it comes to managing dizzy patients, it takes an army. And so dizziness is unfortunately a common and potentially life-threatening condition. And if left untreated, it can lead to falls and serious injuries. So when possible, a multidisciplinary approach with the integrated strategy that includes fall prevention is more effective in the diagnosis and management of dizziness because the underlying causes often span multiple body systems and are not amenable to simple pharmacotherapy. So again, these are the conversations that I have with my patients, and hopefully you gain some benefit from this discussion. And if you have any particular questions, I'd be happy to take care of them now.